use of nitric oxide in neonates. So the specific learning objectives of this talk will include history, one of the animal experiments which was done to prove the basically the mechanism of nitric oxide, introduction to nitric oxide, mechanism, indications, time of initiation, steps in initiation, and then at what dose the engine has to be started, how do you how do you see the response and failure, escalation of duration, weaning, discontinuation, some trials and take home. So the beginning. So it started from the Alfred Nobel. So this nitroglycerin molecule, it was originally synthesized by Sobrero, and then it was used by Alfred Nobel to manufacture dynamite. And then from this came the invention of this nitric oxide, which is the also called as the endothelial derived relaxing factor. So this was one of the experiments done by Professor Lakshmi Simha, which was published in Pediatric Research in 2009. So there, this graph shows various curves where there was resuscitation done with 21% and comparison with 100% oxygen. So this is a this DH is dihydroethidium. So it was tested on this one DSB is 1 day old spontaneous breathing fetal lambs. So it was tested, and then gradually the fetus was exposed to 100% oxygen and then 100% oxygen plus nitric oxide. So as you can see in the picture, the third picture where the 100% oxygen is used, there is a thickness at the pulmonary arteriole. So 100% oxygen giving is detrimental. And as you see in the next slide, which is when you add nitric oxide to 100% oxygen, there is a tremendous decrease in the thickness of the pulmonary vasculature. So I'll just brush through these slides in view of paucity of time. So the INO was first approved by the Food and Drug Administration in 1999. And it has been the mainstay of treatment for PPHN in newborns, and it has also been shown to reduce the need for ECMO. So as we all know, it is a selective pulmonary vasodilator. It usually affects the pulmonary vasculature instead of the systemic vasculature. So this is the mechanism of action. So L-arginine is the amino acid, and with the help of this nitric oxide synthase, NOS, this nitric oxide is produced. Then this nitric oxide gets diffused from the endothelial cell to the smooth muscle cell, and thereby causing the relaxation. So this is the actual mechanism of action of nitric oxide. So there are other mechanisms also, like it decreases inflammation, it decreases vascular leak, it preserves the vascular endothelial growth factor expression, and it also alters your gene expression. So coming to the other mechanism, so usually the for the appropriate action of nitric oxide, you need a appropriately recruited lung. So here from this diagram, you can see that NO preferably goes to the ventilated alveolus as compared to a non-ventilated alveolus. So this effect is known as the microselective effect. So the take-home message from this slide is that NO has a microselective effect. It usually will go to your ventilated alveoli as compared to the non-ventilated alveoli. So these are the approved uses of nitric oxide, PPHN, and where there is confirmed PPHN and the gestation is more than 34 weeks. Or if the oxygenation index is more than 25, even people have used a lesser oxygenation index where it is come down to around 15 to 20. So always the oxygenation index doesn't have to be 25 in order to start nitric oxide. And the third is need for 60% oxygen. If you have to maintain, if you are trying to maintain the pre-ductal saturation more than 90%, usually the optimal dose is 20 parts per million. And we have to take into consideration some conditions in which there is a caution or we cannot use INO. So these are congenital diaphragmatic hernia, left ventricular dysfunction, or there is hypoplastic left heart cell. Also, in asphyxia and sepsis, you need to be cautious. So these are the indications of using any three terms. Not much evidence is there, but you will consider in those preterm infants in which there is a history of prolonged rupture of membranes and there is PPHN physiology plus equivalence. So these two I have crossed because early hypoxic respiratory failure without PPHN is not an indication to use NO, and it has no prevention of DPT. So this guideline came from the American Heart Association and the American Thoracic Society that it can be beneficial for preterm infants with severe hypoxemia that is usually due to PPHN physiology rather than parenchymal lung disease. So appropriate time to start is over 25. I think the steps in initiation can be discussed in the workstation, so I'll just skip it. The starting rate is 5 to 80, but most of the RCTs have started with a dose of 20 parts per million. And usually, if you don't get a response at 20, it has been shown that you will not get a response even if you increase it. So how do we assess the response? So response is assessed by, so there is a classification which from Goldman et al. Who had classified patients into responders and non-responders. So what is the definition of a responder to INO? Where the PaO2 increases by 20% and there is a fall in the OR after 30 minutes of starting INO. So basically the responders were classified into three categories. One is early failure, then the second was sustained responders. So the first is, so the examples I've just highlighted in black that what are we called, usually babies who have early failures are babies with CDH, pulmonary hyperplasia, secondary to oligohydramnios. And in the sustained responder group, usually the babies had MAS, meconium aspiration syndrome, PPHN, and RDS. The third category of babies are into prolonged dependence who require nitric oxide for a prolonged period of duration for more than 2 to 3 weeks, and even it can be extended to 6 weeks also. But most of the babies died in this group, as studied by Goldman. So when do we call failure? As we discussed, as it has been discussed in the earlier lectures also, that how do you assess the oxygenation of a newborn whenever you are starting on the baby on a ventilator. So we see the A by A ratio, that is the arterial by small a by capital A ratio. If it is less than 0.22, it defines that this is your NO is not working. You can still go incrementally up to 80 ppm in like dire conditions, but usually it is very unlikely that you will get a response at this high dose of nitric oxide. So toxicities is usually methemoglobinemia and formation of nitrogen dioxide, which is a more toxic molecule as compared to NO. So if the levels of methemoglobinemia rise to more than 10%, then you have to temporarily discontinue the nitric oxide. And likewise for NO2, if the NO2 concentration rises to more than 5 ppm, then you have to temporarily withhold your nitric oxide system. And there are chances of bleeding, particularly in the preterm. So when we escalation, as I told you, we can go to maximum of 80, but there are risks of methemoglobinemia. So this slide, as I already told you, usually the optimal dose and the maximum dose is around 20 only. So the duration is typically 5 days. If you are requiring nitric oxide for more than 5 days, then we have to investigate for other causes also. And the maximum duration of INO, what has been studied in all the trials, has been around 14 days. So how do you wean? So the starting, as I told you, the starting rule, you can just remember two rules are there. So the 20-20-20 rule, that is for initiation. And initially the rule was 60-60-60, but the research from Professor Satyan in 2015, the rule has changed to the 30-60-90 rule. So if there is oxygenation, so it is for 60 minutes, and then if the FiO2 is coming down to more than 60%, and your SpO2, which is measured by pulse oximetry, is more than 90, then you can gradually cut down on the INO. This is one of the other strategies of weaning INO, like from 20 parts per million to 15, 10, 5. And once you come down to 5, every 4 to 6 hours, you reduce by 1 ppm until unless you reach 1. And then from 1, you can gradually, you can discontinue the nitric oxide. So this is the recent weaning approach published by Souvik Mitra from Canada. So after clinical response, INO will be weaned by 50%, provided the oil is less than 10. The pre-ductal SpO2 does not decrease by more than 5%, and the FiO2 is not increasing by more than 10%. So we should avoid abrupt cessation of NO because it can be counterproductive, and then again there can be rebound hypoxemia. So when do you discontinue? When the FiO2 requirement has come down to less than 60%, and your PaO2 on the blood gas is more than 60, and there is no evidence of rebound pulmonary hypertension. And if the increment FiO2 has been more than 15%. So this is the summary of INO use. This is the summary of INO trials. So as you can see that this is a forest plot, and the red and the diamond, that is the summation of all the trials. So it has been shown to reduce the need for ECMO and death whenever it has been used for PPHN and newborns. So this is a bubble diagram showing the same thing, that there was increment in the oxygenation index and decrease in the death. So one of the recent studies showed that NO can cause cancer also. So the take-home messages is this INO improves the oxygenation and decreases the ECMO use. So evidence is start on at 20 ppm until unless there is a real need, then only you escalate, because the more you escalate, the problem with methylhydrogenemia comes, and only it has to be done in centers where ECMO facilities are there, because already the oxygenation index is high, and you can land up in a situation where the oxygenation index can easily go to more than 40. So which is a clear-cut indication of initiation of ECMO. So there is an increasing evidence of more INO, but still more papers have to come in order to validate this use. And also it has been shown that INO is an anti-inflammatory therapy, but still this thing has not come into routine practices, more for research studies. Thank you.